Hello, and welcome to a very special Facebook Live broadcast with MedStar Health. My name is Karen Zingle, and today we'll discuss a very important topic, lung cancer screening. November is Lung Cancer Awareness Month, and did you know that approximately 235,760 people across the country will be diagnosed with lung cancer this year? The good news is that early detection is key to beating any form of cancer, and knowing your risk factors can determine if you need to be screened. I'm joined today by several experts from the MedStar Georgetown Cancer Institute. Dr. Pamela Randolph-Jackson, radiation oncologist at MedStar Washington Hospital Center. Dr. Joshua Royce, medical oncologist at MedStar Georgetown University Hospital. Dr. Irina Veytsman, medical oncologist at MedStar Washington Hospital Center, and Dr. Jessica Wang Memoli, interventional pulmonologist at MedStar Washington Hospital Center. Thank you all for joining us today. We really appreciate it. And to our viewers, we invite you to give us a like, let us know you're watching, and comment with your questions. We also invite you to share this broadcast with your friends, especially those who would benefit from learning more about lung cancer screenings. So before we get started with our questions, let's meet our experts. I'll start this morning with Dr. Veytsman. Want to introduce yourself?
Hello, I'm Dr. Irina Veytsman. I worked at the Washington Hospital Center, and I'm part of the thoracic oncology team here, and as well as the Georgetown Cancer Institute.
Thank you. And Dr. Memoli?
I'm Jessica Wang Memoli. I'm one of the pulmonologists, and specifically an interventional pulmonologist here at MedStar Washington Hospital Center. I've been here for over a decade. When I kind of think about that, that's been a long time. Work closely with Dr. Veytsman and Dr. Randolph-Jackson and all our lung cancer patients here.
Thank you. And Dr. Royce?
Yes, hi, I'm Joshua Royce. I'm a thoracic medical oncologist here at Georgetown Cancer Center, Georgetown MedStar Cancer Institute. So I specialize in the treatment and care of patients with lung cancer, and from the medical oncology side, so that means systemic treatments that go throughout the whole body, including chemotherapy, targeted therapy, and immunotherapy. And I'm excited to be here today.
Thank you. And Dr. Randolph-Jackson, perfect timing. Welcome back.
Right.
Yourself?
Yes, I'm Dr. Randolph-Jackson. I'm a radiation oncologist at the Washington Hospital Center. I practice in the DC area for probably the last 30 years, and we treat lung cancer throughout its stages.
Okay, thank you very much. Welcome again to all of you. So let's get into some questions. Dr. Veytsman, I'm going to start with you. Is lung cancer common?
Thank you, Karen. Yes, lung cancer is the second most common cancer, accounting for about one out of five malignancies in men and about 1 out of 9 in women. And unfortunately, over the past several years, while incidence of the lung cancer is reducing, unfortunately, there is definitely a rise of cancer in female population. For example, if you look back in 1940s, we had about only 7 women diagnosed in 100,000 population, and now about 42 females diagnosed with lung cancer in 100,000 population. And unfortunately, all of that evidence points out to the smoking as the cause.
Thank you. Dr. Memoli, do you want to expand on that?
Yeah, and while lung cancer is the second most commonly diagnosed cancer, unfortunately, it's the most common cancer death. So when people die of cancer, most commonly ends up being lung cancer. And I think that's a really big problem because, you know, we are diagnosing it a lot, but people are really succumbing to it, and actually leads to death more often than a lot of the other actual cancers combined. And so that's really something that we try and strive to work on with what we do.
Thank you. Dr. Royce, can you talk about when lung cancer is caught?
Sure. So obviously, you know, we are going to treat patients with any stage of lung cancer and hope to improve survival and quality of life no matter when you're diagnosed. But the problem is if we wait for symptoms to develop, that is usually at a point when the cancer can no longer be cured, is no longer isolated to just the lungs or just the lungs and lymph nodes. And that's because the lungs are, a highly adapted organ. So a nodule or even a growing tumor oftentimes will not have any symptoms associated with it. And so symptoms oftentimes won't develop unless there's critical airway obstruction or, if there is spread to another organ causing pain or altered function of that organ. And so that is why screening is so important, because it allows us to catch cancers in an earlier stage.
Right, thank you. Dr. Randolph-Jackson, can you talk about the number of lung cancer cases and deaths and what's happening with those trends?
Sure. So the number of lung cancer deaths is dropping secondary to people stopping smoking, as well as early screening and early treatments. They had a large study, the NLST, who looked at a randomized 53,000 patients to either low-dose CTs versus chest x-rays, and they found that the low-dose CTs decreased the mortality rate by about 20%. They also did a study at NIH where they examined the impact of tobacco control policies and programs. And those, if you're old enough like I am and remember, those that include, stop smoking, cessation in public areas, smoking on the plane, decreasing the incidence of the youth, young smoking early, and that sort of thing. And what they found with those control programs, that they had a prevention in deaths of approximately 800,000 patients between 1975 and 2000. So it just goes to show, with all of the things that they're doing now, we are decreasing the incidence of smoking as well as its impact on the population. And interestingly, back in the 60s, it seems like there were greater than 40% of the US population smoked. And now we're in the range of 15 to 20% of the population still smokes.
Wow. That's great news. Thank you all for helping us to understand how common lung cancer is. Let's talk about who is at risk. Dr. Royce, can you start by talking about who is at risk for lung cancer?
Certainly. So, I think this echoes what my colleagues have already brought up. But, our most number one risk factor for lung cancer still is smoking and tobacco exposure. This is associated with pretty much all forms of lung cancer, some more than others. Small cell lung cancer, for example, which is our most aggressive subtype of lung cancer, is almost exclusively associated with smoking. But that's smoking is not an exclusive risk factor, and there are several other potential factors, and in many cases, no factors at all. And I know some of my other colleagues will touch base on that as well.
Yep, thank you. Dr. Memoli, can you talk about some of those other factors?
Yeah, sometimes there's things that can contribute to lung cancer that we don't even think about. I think one of the biggest influences aside from tobacco is asbestos exposure, which I think in this day and age is a little bit less common. We were smart enough a few decades ago to learn that if you're around asbestos, you should wear masks, and there's asbestos remediation. But that doesn't mean other occupations that weren't necessarily as intimately associated with pulling out ductwork in houses couldn't have influenced. We've seen increased incidence of cancer in, or as a risk factor, dental workers, because they were doing a lot of drilling and aerosolizing of all those fumes, and other potential occupational exposures, things like radon. So if you haven't ever checked the radon in your basements, it's probably not a bad idea to check the level of radon in your basements, because that's another form of radiation that you could be getting that can contribute. So there's a lot of other environmental, occupational hazards that can add to, or even exponentially add to, the risk factor from smoking. So if you've had smoking plus some of these other exposures, your risk is that much higher.
Thank you very much. Dr. Veytsman, what about family history?
Yeah, a lot of people actually ask about that because they want to know if when they diagnose with lung cancer, if their family is at risk. So the role of genetic factors as the cause of lung cancer is not really well understood, but there is definitely an evidence suggests that family history can play a role, especially if you have multiple family members that are affected by cancer. Also, if the lung cancer happened at a very young age. So we do like to look into the genetic factors. And there are some other, obviously, factors besides family. There's some studies point out towards other like estrogen progesterone therapy associated with increased risk. There are some other consumptions of maybe vitamins and stuff. So there are a lot of work ongoing into that field as well.
Thank you. Dr. Randolph-Jackson, what about healthcare disparities that could be a factor?
Well, Black people are usually diagnosed with lung cancer and have worse outcomes because they're diagnosed at a later stage when you compare them to their white counterparts. We are also 16% more likely to be diagnosed, as mentioned, at the later stage, 19% less likely or more likely not to have surgery as our primary treatment choice, and 7% more likely not to have any type of treatment whatsoever. About a half of the 30 million uninsured Americans are people of color. So there is a disparities piece in there. Some of it, I think, is the fear of knowing. And the other aspect is poor insurance coverage.
Thank you very much. Well, let's talk more about those lung cancer screenings and how you can find out in those early stages if you have lung cancer. Dr. Memoli, will you talk about what a lung cancer screening is with the low-dose CT scan?
Yeah, I think some of my colleagues have already touched on lung cancer screening. Lung cancer screening sort of became a little bit more common, and something that we actually recommended in 2011 after this NLST study that Dr. Randolph-Jackson mentioned, because they showed that there was a 20% mortality reduction when we did lung cancer screening CTs. And essentially what that is it's a CT scan, similar to any other kind of CT scan that you do, but the reason why it's called a low dose is because it comes with a little bit less radiation. So as a lot of people know, when you get a CT scan, there's a certain amount of radiation, and a regular CT scan of the chest gives you about 3 months worth of radiation. So everybody gets radiation walking around on the street, in your house, just, in daily life. And they sort of quantify how much radiation based on what you would get if you didn't have any of these imaging studies. And with a regular CT scan that you may get to look for something, it's about 3 months worth. With a low dose CT scan, it's more than half, it's less than half of that amount of radiation. So it's a significantly smaller amount of radiations, a little bit over 6 months worth of just regular radiation. So that's good news. And so you can feel a little bit more comfortable about your risks of radiation just from your low dose CT scan. It takes about 10 minutes. It's pretty quick. You just go into the CT scanner and you come out. They have you take a deep breath. And so it's not, even really that exciting. In the NLST, they found that patients were pretty good about adhering, and we have some programs here at the hospital center at Georgetown to sort of help with getting it done in the process, which I think we'll get into in a little bit. And then I think when it comes to insurance, and I think we'll touch on that a little bit too, the Medicare and Medicaid in 2015 came out and said that they would pay for lung cancer screening, which is really, which was a big day, very exciting for all of us who are in this world, because that really opened it up for a lot of patients. Most of the commercial insurances started before that, but when Medicare and Medicaid said that, it was pretty exciting, and it really helped us ramp up our programs here.
Thank you very much for that. So it's simple, it's a painless test, doesn't take very long, and you mentioned the insurance coverage. So thank you for explaining that and explaining what it is with the low dose and that part of it. Anyone else on the panel have anything to add to what Dr. Memoli mentioned in terms of the scan itself? Okay, well, Dr. Randolph-Jackson, who should have a lung cancer screening with a low dose CT scan?
So the recommendations, and try to say this fast 50 times, USPSTF suggests that you're between 50 and 80 years of age. You have a 20-pack year history, meaning that you have smoked a pack a day for 20 years or 2 packs for 10 years. And you either can continue to smoke or have stopped smoking within the last 15 years. And so I'm going to pass it off to Dr. Memoli in terms of how this has changed from prior recommendations and if it's covered by insurances.
Yeah, so, I mentioned in 2015, Medicare, Medicaid said, oh, yes, we'll pay for it. The USPSTF actually in 2013 put it out as a recommendation that patients should get a lung cancer screening if they're at high risk. So the initial guidelines were a little bit more narrow than the ones that Dr. Randolph-Jackson just said. So it was ages 55 to 75. Patients who have smoked within 30-pack years, but quit within the last 15 years. In the new recommendations that just came out this year, those age ranges were expanded to 50 to 80, and the length of smoking was decreased to 20-pack years. And the main reason for that is based on some of the healthcare disparities that Dr. Randolph-Jackson had mentioned, in that a lot of the Black African-American population tends to get diagnosed at an earlier age. And so hopefully by screening them at an earlier age, we can find them at an earlier stage that's then curable. And that's really the big reason for the change in recommendations. Because this recommendation just came out in March of this year, sometimes insurance companies, including Medicare and Medicaid, lag. So if I don't know if you remember, I mentioned that this big seminal study came out in 2011, but it took Medicare and Medicaid 4 years to decide that they were going to pay for patients to undergo screening. So I expect that it may take a little bit of time before Medicare and Medicaid agrees to pay for this expanded screening population. However, a lot of the private insurance companies are already paying for this expanded population. So if you have smoked 20-pack years, are between the ages of 50 to 80, and have quit within the last 15 years and are asymptomatic, you may qualify according to recommendations. So don't let the idea that you're at 27 years of smoking kind of keep you from going to your doctor and sort of asking about lung cancer screening.
Right. Thank you very much. Dr. Veytsman, how often would someone need to get this test? Is it something that you would get every year if you meet those qualifications, like you would a mammography or a mammogram or a colonoscopy?
Yeah, so definitely once a year, unless we obviously find some suspicious changes in a scan. But yes, once a year, we strongly recommend it. Colonoscopy usually every 5 to 10 years, but mammogram is yearly, and so there should be a lung cancer screening as well.
Great, thank you very much for that. As I've been doing these broadcasts, one of the things that really stuck with me was anytime you are in need for one of those, it's that time of the year when you need to schedule your annual exams. It could be every year on your birthday or every year on your, one of your favorite sports days. So that's something that I thought I'd share with our viewers that really stuck with me, that as you were thinking about your lung scan and getting that every year, maybe tying it into something on your calendar for that reminder.
And Dr. Memoli, when do you stop? You take
so that's a good question without a clear answer. So typically what we do is we stop when the patient sort of either ages out or they're sort of, they age out in terms of when they quit, or if they're older than 80, for instance, and then they sort of no longer qualify. So then we stop doing it. There's not a ton of data sort of looking what happens after a certain number of scans. And if, hey, you've had 5 normal scans, does your risk go away? And that may be something that will need to be looked at in the future. But as of right now, we basically continue to do it every year until they kind of age out.
Good to know. And Dr. Memoli, what does the scan show?
So I like to tell my patients it can show two things. One, it can be totally normal, meaning that we don't see anything exciting, nothing that makes us worried. Everything looks normal. The other possibility is that there's something abnormal, and that abnormal can be within the lungs themselves or even outside of the lungs. So if you think about it, when we take a picture of the lungs, it's not just the lungs. There's all these other organs that are close by. Your thyroid, we kind of get some of your kidneys, we get a little bit of your belly, we can see your heart. So there's other things that we can see besides what's just in your lungs. So when we see something abnormal, we can see something abnormal in your outside of your lungs, or we can see something abnormal within your lungs. And then I tell people, well, within the lungs, it could be something like emphysema. So, a lot of these patients, to be able to get a lung cancer screening CT, they have to be smokers. So the chance of having emphysema is pretty high. And that's just damage to your lung from smoking. It doesn't necessarily mean that it's cancer. It just means that, your lungs were damaged because the smoking destroys some of those air sacs in your lungs. And we see that. It could also mean you have some scarring in your lung if you have something abnormal in your lung. It could mean you have an infection. During this COVID time, everybody was out there saying, oh, we can tell people have COVID just based on their CT scans. So there's other things. And then there's the chance that we find something that might be cancer. So usually we call it a little nodule or a spot or a mass in the lung. And when you hear those words, that's when you start thinking, oh, okay, that makes you a little bit more suspicious for lung cancer. And so those are the ones that we are really looking for. All the other stuff is stuff that's concerning, but we sort of aren't usually worried about lung cancer at that point. We may have to do some other workup or management for those, but really for the lung cancer screening is when we see one of those spots or dots or nodules or masses.
Thank you. Do you need a doctor's referral to get a scan?
Yeah, you do for most places who are doing lung cancer screening. Here at MedStar Washington Hospital Center and at MedStar Georgetown University Hospital, we actually have a dedicated group that takes care of lung cancer screening. We make sure that the patients qualify. So we make sure, that they're within the right age range, have smoked the appropriate amount, and that their insurance will cover the screen that they get, depending on if they fall within the new expanded criteria versus the old one. And both institutions have a nurse practitioner that also follows all the patients who come through and gets a lung cancer screening CT. And so, it's a whole process and program to make sure all of that happens. If a patient calls and says, hey, I want a lung cancer screening CT, we can make sure that that order gets in, because again, we have a nurse practitioner to help us with any of that. So even though for the vast majority of patients, they do need a referral from a primary care physician, we do have a process for helping patients who are interested, who may or may not have that referral already.
Thank you very much. It's really helpful. I want to pause for a moment just to remind our viewers that if you have any questions for our panel, to please post them in the comments. Give us a like, let us know that you're joining, and share this broadcast with your friends. We've shared a lot of wonderful information already about lung cancer screenings. We have some more questions for our panel, so please ask those questions. Dr. Memoli, can you talk about what someone would expect when they go in for a lung cancer screening?
I'm sort of monopolizing the discussion here a little bit, but having helped create sort of our program here, this is a little bit near and dear to my heart. But here at Hospital Center, what we do is we bring patients in. So we sort of have two groups of patients, some who have had a discussion with their primary care doctor. Their primary care doctor says, hey, you qualify for lung cancer screening. Here's some of the risks of lung cancer screening. So this is what we can potentially find. All those things that I went through about, abnormalities both in and outside of the lungs. And some of those abnormalities may have nothing to do with lung cancer, Those are some of the risks. And then what we'll do if we find something abnormal, which we'll get into, and that's what we call shared decision making. So some patients who go through that whole process with their primary care physician, if that's been documented, then they come in and we just schedule them for their lung cancer screening CT. They come in and they get it done and they leave. For patients who haven't had that discussion yet and sort of need to have that discussion to make sure that they feel okay getting the scans done, we actually come in and they meet our nurse practitioner and have a whole discussion with her, make sure that, you know, the patients have no symptoms, they understand all the things that we're talking about here, and then we send them for their scan on the same day. And then afterwards, usually about later that day or the next day, when we get their results, we'll contact them and go through that.
Thank you. Speaking of results, Dr. Veytsman, how quickly do you get the results?
Well, we try to communicate the same day or at least the next day. So as Dr. Wang Memoli mentioned, we have a nurse practitioner who follows the patient immediately and discuss results with the patient. If there are some findings, like Dr. Wang Memoli mentioned, we do have a team of doctors that we review those suspicious scans once a week, and then additional information gets communicated to the patient as well.
Thank you. Dr. Randolph-Jackson, is the lung scan invasive?
No, it's totally non-invasive. It's almost like it's probably one of the most simple things that you can have done.
Wonderful. Dr. Royce, are there any side effects?
Well, you know, as Dr. Randolph-Jackson mentioned, this is a painless, non-invasive procedure. It's a scan. It's not a colonoscopy. There's nothing invasive. There's no biopsies that are happening as part of this. So in terms of direct side effects, those are very minimal. I think patients might wonder, well, is there any long-term risks to radiation? And I think, when we talk more about long-term risk with radiation therapy, this is a low-dose CT scan, so there's more minimal doses of radiation than a standard dose CT scan. And, in looking at the screening trials, they're accounting for all of these factors. And so we know that the benefits of screening outweigh any potential risks from that standpoint.
Thank you. So Dr. Veytsman, where can you get a low-dose CT scan?
Well, MedStar made a huge effort to accommodate patients population that we cover. And so each region has the screening program. So in DC, we have it at Hospital Center, Georgetown. We have screening programs through South Maryland, Montgomery General, and the Baltimore area. So very convenient, very easy. Just pick the number, a call. And there's a whole effort from the Department of DC Health to actually also kind of ease up the way to refer, so through the computer system that we are working actually now with Georgetown, trying to implement that through the computerized system.
Thank you. So let's talk about what happens if something is found on your lung scan and the treatment options. We'll get into that after that. Dr. Veytsman, can you talk about what happens if a spot is discovered on your scan?
So sometimes we discover spot, and that's the reason for lung cancer screening. And we assign there's a whole scoring system. So we assign the specific lung score to each spot, and that gets reviewed against any suspicious scoring system gets reviewed by our special radiologist that designated to the lung cancer screening program. And on multidisciplinary team, once a week, we review that. And then depending on the risk, we can identify actually a lung cancer risk based on that score. And we have a whole system implemented that if we do have a higher score, those patients undergo a specific route of investigation. And like Dr. Wang Memoli mentioned, not all spots can be cancer, so we have to make sure we proceed with diagnostic route or other routes, which we have a very implemented system within the hospital center in Georgetown of referral patterns and processes.
Thank you. Dr. Wang Memoli, can you talk about the diagnostic tools and biopsies that we would do?
Yeah, so once something is found, as Dr. Veytsman said, there's a bunch of different things that we could potentially send them for. And if we're talking about the need for a biopsy, there's a few different ways that we can do it. One is, I'll start from sort of the most invasive, which is surgery. So sometimes we send patients directly to the surgeon and we say, you know what, this thing just needs to come out. The suspicion is high that it's lung cancer. It doesn't look like anything else is involved. And you're a good surgical candidate. Just let's send you to the surgeon. The other option is that we do some sort of a biopsy beforehand. And there's two different ways that we can do those biopsies. And one is what's called a CT guided biopsy, where we send you to a radiologist and they take a look, they do some imaging and they basically numb up your skin and go from outside in. And do it that way. It's same day in and out. The other way is to do something called a bronchoscopic biopsy. And at Georgetown and here at Hospital Center, we have some new technology called a robotic navigation bronchoscopy, which is really quite exciting. We're one of the first places in the Mid-Atlantic actually to get one of these robotic navigation bronchoscopy systems. Each hospital has one. And it really allows us to be more precise as we go out into the lungs to do biopsies. One benefit of doing it bronchoscopically versus doing it by CT guided is just the risk of causing some damage to the lung. So our risk of causing damage to the lung when we do it bronchoscopically is a little bit lower. We're also able to do what we call staging. If it ends up happening to be lung cancer, we can look to see if it's spread anywhere. So that's some other things that we can do. And then least invasive is at times we may say, you know what, we need a little bit more information. Maybe we need to just repeat your scan. Maybe we need to do a different kind of scan, like a PET scan. So there's sort of different possibilities of what we may do for the next sort of diagnostic step.
Thank you. Dr. Royce, can you talk about the treatment options, what a patient would do to look at those different options that are available?
Sure, so that's a big question, but I'll see if I can break it down
Okay.
succinctly here. So when I first meeting a patient, either as a part of our interdisciplinary clinic or on my own in clinic, I like to tell them I have three big questions that I'm trying to address. One, what is it? Two, where is it? And three, how do we treat it? And so the answers to the first two questions will inform the third question. So what is it? You know, it involves really what that entails is a biopsy. And that, you know, was performed by my colleague, Dr. Wang Memoli, or colleagues in IR to get a piece of the cancer tissue, where we can look at it under the microscope to say, you know, what is the unique subtype of lung cancer. And I mentioned this earlier, we have several subtypes. One is something called small cell lung cancer, which is our most aggressive type of lung cancer. The other broad category is non-small cell lung cancer. And our treatment options vary depending on the underlying type of cancer. So that's what is the cancer. Where is it? And, you know, that's really screening is the first part of that, but it's not the only part. So, you know, if we see something on screening and we do a biopsy to show that, oh, there's cancer in this one spot, we first have to assess, is there cancer in any other spots in the body? And that oftentimes entails additional scans. One is called a PET scan, which basically patients get injected into their system, kind of like a radioactive sugar, you could think of it as. And sometimes that allows us to see areas that might not appear on the CAT scan, areas that are concerning that might suggest the cancer is spread outside the confines of the lung. The third type of scan that's done is an MRI of the brain, because we know that lung cancer, one of the areas it can go to is the brain if it spreads. And oftentimes that is without symptoms, but that is hugely important. All of these scans are important because where the cancer is informs what treatment options we will offer and what is the best option for you for the treatment of your cancer. Unfortunately, if the cancer has spread outside of the lungs, this is a scenario where we consider this a metastatic or stage 4 cancer that is not usually curable with things like surgery or definitive radiation. That's usually where a patient would see someone like myself or Dr. Veytsman, more medical oncologists that specialize in treatments that go throughout the whole body, such as chemotherapy, immunotherapy, targeted therapy. How do we answer the question of what treatments are best? Well, we oftentimes do additional testing on the cancer, something called next generation sequencing, which allows us to get a complete molecular profile at the DNA level, really at the most You can think of it as the most microscopic and submicroscopic level that informs us on what is the best systemic therapy for our patients. Now, if we're lucky enough with screening to catch the cancer at an earlier stage, but where surgery and radiation are potential options, then oftentimes the utilization of those techniques, potentially with chemotherapy, depends on how advanced the cancer is. And we will now oftentimes also employ this next generation sequencing to help us with additional systemic therapy options. Very exciting. In the past year, immunotherapy and targeted therapy called Tagrisso, which targets a unique lung cancer mutation in a gene called EGFR, are now approved in patients that can have their cancer removed by surgery. So these additional treatment options will hopefully help to prolong survival for our patients. And then we also have several clinical trials available for other types of subsets that might be identified with this additional testing. So I know I just dominated a bunch of time there, but that in a very large nutshell is kind of a breakdown of how we treat the various stages of lung cancer in our clinics.
Thank you so much for that. And I think you covered the various treatment options that are available. And Dr. Wang Memoli, you mentioned the surgical options. We talked about immunotherapy, the targeted therapies. Dr. Randolph-Jackson, what resources are available for patients so they can learn more about the treatment options or even the scans themselves?
So I love the internet. So that's probably the best place to go to find anything you want to know about lung cancer or smoking cessation. Some of the ones that just off the top, I wrote them down. CDC.gov is a great one. Smokefree.gov is a great one. Prevention.va.gov, nccn.org. There's a host of information out there at the touch of the finger to find out anything you want in terms of lung cancer prevention, treatment, smoking cessation, and so on and so forth.
Thank you very much. And Dr. Royce, we talked a lot about the MedStar Georgetown Cancer Institute. Can you talk about our affiliation with an NCI CCC designated cancer center and the benefits that gives our patients?
Certainly. So, that is incredibly important that we have this designation. It means that we are a recognized cancer center to provide comprehensive cancer care to our patients. And so, this enables us to, for several things. One, we have specialists working in multiple disciplines that come together to treat all aspects of the person, not the patient, is like what I like to say. A person is more than their cancer. And so it's important to have multidisciplinary input that addresses various comorbidities, various aspects to the care. And at a comprehensive cancer center, we're able to address that, including in an interdisciplinary format, where oftentimes we can see patients. I can see a patient together with a radiation oncologist, a surgeon, and a pulmonologist to make a dedicated recommendation that is consensus all in one visit. We also have several trials that are actually sponsored through the NCI. And so between the clinical trials and the level of expertise, these are some of the reasons why a comprehensive cancer center is important. And I'll add this too, a patient might say, well, I live, it's great. I'd love to come to Georgetown or Washington Hospital Center, but I live, 2 hours away. How can I still involve these providers in my care? And the answer is 100% yes. We want to make this as easy for you as possible. And so whether that's making a recommendation that then is executed at a local center, or once you're in our system, I like to say, you're there for good. And so if down the road there's a complication, there's interest in a future clinical trial, once you're plugged into our network, you're always in our network. And so these are some of the reasons why coming to a place like us, a comprehensive cancer center, or one of many other cancer centers, comprehensive cancer centers in the nation, is a great idea.
That is wonderful. Thank you very much. Dr. Veytsman, what message would you like to send our viewers before we wrap up our broadcast who are eligible, thinking about getting a lung cancer screening, or anything else that you'd like to add before we wrap up?
Well, we definitely recommend to, if any doubt, are you eligible or not, talk to your primary care or pick the number and call us. We will certainly walk you through eligibility and define if you're eligible for lung cancer screening or not. Another important factor, lung cancer screening, doing CT is not just enough. Smoking cessation is another priority. And part of the lung cancer screening program. Again, Georgetown and us, we're part of the whole national effort to improve lung cancer survival, and smoking cessation actually plays a huge role in that, and sometimes makes a bigger difference than even some of our treatments that are available. So we have a STAR program that organized through the MedStar facilities that emphasize smoking cessation, helps to screen those patients and start them on a treatment. So that's another important factor to remember. And another factor to remember, we do have treatments. So if we find something, we certainly can help. And you heard Dr. Rose was so excited about different treatment options. So he stole the whole thunder from us.
Sorry, I didn't realize
With
that.
enthusiasm, I may add. He was
Right, but
extremely
we're
enthusiastic.
definitely excited, and there's definitely treatments for you here. So don't be afraid, because I hear a lot that people are afraid what they find, so they don't go to screen. But the whole goal is to find it early, and we can help you.
Thank you. Dr. Wang Memoli, what message would you like to send our viewers?
I think I would just reiterate everything that Dr. Veytsman said: early detection, stop smoking. And just because we find cancer doesn't mean that that's the end. It's amazing the things that have come out in the world of lung cancer care in the last, I said I was here for about 10 years. In the last 10 years, it's amazing. Like every time Dr. Veytsman, we meet for our tumor board, and she tells us there's this and there's that and there's this new treatment, and I'm just like, oh, I can't even keep track. It's just amazing. So remember, it's always treatable. It may not be curable, but it's always treatable. And I think we have to keep that in mind as we're looking at lung cancer.
Thank you so much. Dr. Randolph-Jackson, how about you? What message would you like to send our viewers?
I agree with everything that has been said thus far, but what I'm gonna really, really stress is the camaraderie amongst the individuals in our team and treatment team and lung cancer. We get along well. We do the best we can for patients, and it shows at every meeting that we have every Thursday at 7 a.m. So I would say that anyone that comes to the Washington Hospital Center or to Georgetown are definitely in good hands with very caring physicians.
Thank you so much. Dr. Royce, how about you? What message would you like to send our viewers?
Sure. So I think, to me, what I'd like to say is, patients, maintain hope, never lose hope. And I think, one fear someone might have in obtaining screening is, well, what if they find something, and what will that mean? And does that mean that my situation is hopeless? And it 100% is not. And, to echo what my colleagues have said, the advances in the field have just simply been tremendous. So one of the reasons I entered oncology, in particular lung medical oncology specifically, is just the pace of development in the field has been astronomical. We are able to cure more patients. We are able to extend survival incredibly for patients even with metastatic lung cancer. We're even getting to the point where could we say that patients who are treated with immunotherapy-focused treatments and other treatments with metastatic lung cancer, are there some that we are curing? This is something we could never even dream of asking just 10 years ago. So, it is just I feel very fortunate, the advances that have been made, but what patients can take away from this is that there will always be hope. As Dr. Wong Memoli said, we might not be able to cure all patients, but we definitely can treat all patients, and we hope to prolong survival, quality of life, and allow you to continue your life without hopefully fixating on a diagnosis of cancer.
Thank you. Those are all wonderful messages to wrap our broadcast. Thank you again for your time and sharing all this wonderful information with our viewers. I want to thank our viewers for tuning in. This replay will be available. If you missed any of the broadcasts, you can watch it on our Facebook page. And I also wanted to mention that if you or a loved one would like more information about our lung cancer screening program, you can call 888-666-3432, or you can visit us online, medstarhealth.org. /safe lung scan, and we will put some links to resources within the comments. Thanks again for joining us. We will see you next time.